Hello. Good evening. Hi, this is Dr. Verdiales from the Georgia office. So normally, every 2 weeks, I will do a Facebook Live in English. So for those of you that don't know me, I'm Dr. Verdiales. Again, I am the Georgia doctor. So I usually will start with something interesting that has happened, or questions that have popped in the last week or so. And today I would like to talk to you about the uses of Lupron. Okay, so Leuprolide is a GnRH agonist, and what does that mean? That means that it works at the level of the hypothalamus, so higher than the pituitary, and it mimics that hormone, the gonadotrophin receptor stimulating hormone. And if you use it short term, it'll stimulate LH and FSH production. And if you use it long term, it will actually inhibit. That's why Lupron um, can be used as a trigger shot, okay? Or it can be used as suppressive medicine. It's just the mechanism of action. So this week it has been used. Of course, we use it all the time as a trigger, but this week it has been used in the office as suppressive medicine in two forms, and I wanted to share that with you. So one of the forms that it was used this week was to do a Lupron flare-up. So 2 weeks prior to starting stimulation. So this lady comes in, and she did not have the greatest baseline. Dominant follicle, FSH was slightly elevated estrogen. So we decided to give her low dose Lupron, so 10 milligrams every day for 2 weeks, and then kind of quiet things down just a little bit to get a better baseline and hopefully have better results. This seems to work real good on women with low reserve, and those tend to have a crappy baseline because of the way their bodies are working. And we sometimes do it with estrogen priming. We try to avoid birth control pills, but because sometimes the estrogen priming, even if you add the progesterone, it's not strong enough. And then it's almost like the ovaries fight it and they create cysts. So, well, this lady, she had done the estrogen progesterone. And when she came back, there was really not a significant improvement in her baseline. So we're going to do a Lupron flare up for her, meaning 2 weeks of low dose Lupron prior to doing a new baseline. The other scenario that we used recently with very successful result is Lupron for endometriosis, again in a suppressive way, because then you suppress the pituitary, then that means that the ovaries don't get stimulated, therefore they don't ovulate, but they don't produce estrogen, therefore the endometriosis heals and hopefully disappears. So people with endometriosis, especially advanced stages 2, 3, that have had failed transfer, either you can do it with Orlisa, but you can also do it with Lupron. You can add some rescue therapy to that for the symptoms, kind of clear the pelvis, clear the inflammation, and then jump. You don't need a period, just jump on a medicated FET cycle. All right, I see that you guys are jumping in and asking tons of questions. So let's see what you got here today. And if everybody has had an experience with Lupron, it'll be awesome if we can share that with the group. If you had a 3AA embryo and a 4AB, what would you transfer first for the best chance of getting pregnant? They're pretty both about the same. I want you guys to understand, and you've heard that from some of the other doctors, including Dr. Kiltz, even though we grade the embryo, it's a very subjective grading. So it's like looking, Dr. Kills love this analogy, and I think it's fantastic. It's looking at a group of kindergarteners and determining which one is going to be the next president and which one is going to be, the one that's not going to do so great with their lives, and just based on their looks in kindergarten. So it's really, really hard, just based on the grading system for the embryos to determine which one is the winner embryo. We've had many times where you have not only a good graded embryo, but a normal PGT tested embryo that does not become a pregnancy. And then the last embryo that maybe was a BC rating, and then that's the one that becomes the baby. So if I was you, I would just go with either one. You can try the 4AB, and see how that goes. My question is, how come I lost 6 embryos while going through IVF at Syracuse, and not once did any doctor try to change my protocol? We're a total loss with no answers. Um, I don't know why your protocol was not changed. Several things on that subject. Unfortunately, IVF is not a sprint race. It is a marathon. It is a long process. Yes, you have the one case that gets pregnant of that one first transfer. That is not the norm. That is the exception. Um, the second issue is with protocols. Just the way the system is set up, if there is a change in the protocol, you have to request a discussion with the physician. I don't know exactly what happened in your case. Also, if you were transferring two at a time, or what was your particular scenario in terms of what happened with your case. But I know that this is very frustrating, and walking out empty-handed is not exactly what you know were thinking of at the beginning of this process. Okay. I am 44. My TSH is 1.21 and FSH is 8. Are these okay for my age? Yeah, your TSH perfect. We like to see it 2.5 and below. The range for TSH is 0.45 to about 5. Most endocrinologists these days want to see it below 2.5, and of course higher than 0.045. So that is great. FSH at 8.1, if it's a day 3, that's pretty good. It would be great to know what your AMH is and see it in conjunction with your day 3 labs, and that will give you a better idea of where you stand in this fertility journey. How does a modified natural transfer different from a medicated transfer? And does it matter if you have certain reproductive conditions? All right, so a medicated frozen embryo transfer, it's just estrogen, progesterone, and we are actually blocking with the estrogen normal ovarian function. So it is not an ovulatory cycle. It is completely manipulated, so you're not going to be making any progesterone. So it's suppressed ovaries and then completely replacing progesterone. A modified natural cycle is an ovulatory cycle that we will manipulate to be able to coordinate the transfer on the embryo. So, usually, well, I use letrozole. You can do completely natural as well and just watch your lead follicle, and then you trigger, because you have to trigger. That's where, the modified thing is, because then you need a day 0 to start the progesterone. But because it is an ovulatory cycle, you will be making progesterone from your own corpus luteum. So then we still supplement progesterone, but in a lot of women, those type of cycles work better. They're a lot gentler in the body. I've had that comment from a few of the patients recently. And it uses a lot less estrogen, since you are making your own by creating the ovulation process and the natural recruitment process with the letrozole by mouth. Okay. And which one works better? there's actually studies, recent studies. I just read an article a few months ago that maybe the modified natural cycle works slightly better. Traditionally, they have always manipulated the cycle. So the traditional way of doing it is the medicated one. It will be kind of the default for most IVF clinics, including CNY. But when I do the post-transfer consults or whatever, if I see one or two failed medicated cycle, I will switch to a natural cycle. Or if you had a bad reaction at any point to some of this medicine, you want to go gentler on your body. Okay. All right. My follicle sizes today are 24, 20, 14, 11, 12, and 11. So they're all over the place. Your estradiol is 1,000. Your follicles are kind of all over the place. Probably triggering tonight. It's not a crazy thing to do. Because, if you wait another day, there's very little chance of that 24 having a good egg. So hopefully you're going to get maybe 2 to 3 eggs based on those numbers. You are a good case to reevaluate for a possible next cycle and do some sort of what I was describing at the beginning, Lupron or estrogen progesterone suppression, to try to see if at baseline your antral follicles, they're all more even, so they grow together. It's always a big challenge when you have such big gaps in the growth of your follicles, because then it's hard to coordinate when is the best time to trigger. Okay. My girlfriend has PCOS and they put her on birth control pill. She had a period for a few days and hasn't gotten one since. We have to see what other medication she's on, what type of birth control she was put on, and what type of diet is she following and what supplements she's on. So it's not like a clear answer. What is the protocol for dual trigger? What standard is there for not advising ACG along with Lupron? So a protocol for dual trigger is actually doing Lupron 4 milligrams. There's several versions of this, but Lupron 4 milligrams 12 hours apart together with some level of ACG. We hold ACG when the estrogen level is too high, usually above 3,000. We will not give the ACG along with the Lupron. There is some, study suggesting that having the Lupron with the ACG might give better eggs. But of course, you're not going to give the ACG if there's any chances of hyperstimulation syndrome. Okay. I am taking turmeric supplements to help with inflammation. When I should stop them prior to my FET? You can actually take them throughout. Turmeric is an herb that is not contraindicated in pregnancy. Will a cervical polyp hinder implantation? No, but it could make transfer complicated because of just mechanical interruption. Okay. All right. My AMH is 3.16. Is that normal for age 28? Yes. Now, it's very important that we understand what lab values really mean. Anytime that you do any form of lab value, whatever it is, whether it's your hemoglobin, your thyroid stimulating hormone, your AMH, you're looking at a point in your history, right? So we will never know what is your baseline. And this is a question that I get very, very often, especially with AMH, because again, the IVF process is diagnostic as well as therapeutic. So you have somebody that comes in and they're 38, for example, and their AMH is 1.5, and you cannot assume that's perfect, even though, rule of thumb, anything above normal, everything above 1 is considered normal. But what is your baseline AMH? So maybe if your baseline AMH at 20 is 5, then at 38, 1.5 is already a decline. And what does that mean in your body? We don't completely know until we go through the process of trying to stimulate the ovaries. But in general, Ashley, 3.16 at 28 is normal. The average that I've seen in my experience, it's 2 to 5 being kind of in that fertile normal range. I have tubal factor infertility. Would mini IVF be sufficient for me? Yes, it could be. Again, we will not know how many eggs we'll get. I don't think that you have to get real aggressive in your scenario, especially at your age with the AMH you have. But we need to understand, and this is a question that I had yesterday in one of my consults. Yes, we don't want to make too many eggs, but you want to have enough raw material to get a decent amount of embryos, because with each process, with each step, you are going to lose raw material. So you might have 25 follicles, but you might get 20 eggs. Out of those 20 eggs, some will die, some will be bad, immature, or whatever. Then you're going to get the ones that fertilize, the ones that die on day 1 or day 2. And then out of the 20 eggs, you might get 8, 10 embryos. Usually a 2 to 1 ratio at the end of the process is considered a successful IVF. Anything above that is super. All right. Okay, I've had fluid in my tube since my baseline for stim before I started meds. What would this be? I had a miscarriage. I've seen that happen to a few patients. Sometimes it's related to inflammation. Sometimes there's an issue with the tubes, or we could be dealing with kind of silent endometriosis as well. There's an inflammatory process in your pelvis. You should not have fluid inside your uterus unless you're having a period. Okay. So, let's see. I know you guys have a lot of questions. I'm trying to go through all of them. I won't be able to answer all of them, but I will try to. Otherwise, you can always message me through Messenger, and I will try to get back to you within 24 hours. What is expected ACG range at 5 weeks? That varies, especially with fertility therapy, where you could have started with twins, then drop down to 1. So we don't really put a number on it. Things that we look for is a gradual increase of more than 60%. And even that is not set on stone. They used to think that at 5 weeks, you should have about 1,500 of ACG. But on this path of fertility, I see those numbers all over the place. So concentrate more on the comparison from one value to the other. And then you should see the pregnancy at 6 weeks. That will really be it for you. So in general, I see a few questions on diet. We do recommend a low carb diet. Dr. Kills recommends a all carnivore or a pretty strict keto. I personally can't do that. I don't feel good going 0 carbs, but definitely for your endocrine system, a low carb diet will do a lot better. In pregnancy, I can tell you that there is an increase in intolerance to sugars. People think that you get pregnant and you kind of crave sugars. In general, that's not the case. You tend to get a lot more nauseous, and there is science to back that up. It's a protective measure. because high level of sugar is what we call teratogenic for the embryo, meaning it causes birth defects. So your body does not want you to be eating a lot of sugars early in pregnancy. That's why the nausea is there. So in general, the best diet through the whole fertility pregnancy process, it's a low carb diet. Get rid of anything that's processed, sodas, donuts, cookies, pasta, and stick close to nature. If you're going to have carbs, you can have berries, you can have sweet potatoes, you can have, carrots. I'd rather you have that than you have the pasta and the bread. So Amy, 44 and AMH of 1.6. Congratulations. That's awesome. You should be able to get good results with those numbers. Okay. What immune testing do you recommend for recurrent implantation failure? Depends. You can get pretty crazy. There's the recurrent pregnancy loss panel that's pretty much autoimmune disorders, coagulation disorders, and genetic disorders. You can look into chronic endometritis, adenomyosis, endometriosis, or you can also look into an ERA, depending on if, how many failures you've had and whether it is a disharmony between the endometrium and the embryo. Sometimes women need a little bit less or a little bit more progesterone to have the optimal spot for implantation. Okay. I've had mild elevated liver enzymes for about a year. I take Actigol to keep them in normal range. I'm unsure if you've heard of that, but is it safe to take them? So I would love to see why you're having elevated liver enzymes. I do a lot of natural health, so I would love to try to help you with that and see if we can get them down to a point that you do not need to take the medication. The liver is crucial in the IVF process because the liver is the one that processes and eliminates hormones. So we are going to be bombarding you with a lot of hormones, and if you don't, and if the organ that is going to clear them is not going to be working optimally, we would have to definitely watch you a little closer, probably give you less medication. So I would love to get you to a place health-wise that you're not taking medication to artificially decrease your liver enzymes. I am 34 with an AMH of 0.6. I've had 2 miscarriages using letrozole. I had an ectopic, a burst tube back in May. Should I try IUI or go straight to IVF? Well, I think that we need to work on your ovarian reserve. 0.6 AMH at 34 is low. So I would try to work on that first. There, between supplements, platelet-rich plasma therapy, diet, human growth hormone, there are things that we can do to try to improve that. And you're young enough that you can still go to IVF if that doesn't work. But I have seen those values go up in a month or two. So I would kind of do like an ovarian body prep, retest your AMH, and then see if IUI would be a good choice for you. And then in your case, I would not be using letrozole. I would give you a injectable protocol such that you will ovulate more than 1 egg from both ovaries. That's going to increase your chance of success during an IUI. Consultation in 2019. Do I need to start a new one? Yes. Anybody that had a consultation of more than 1 year will have to discuss their life changes with a provider prior to starting. Okay. All right. Okay, so Miss Lisa, got 15 eggs after my first PRP with you. After 4 retrieve with just 4 weeks prior. 43 and praying this PRP works. That's awesome. Congratulations. 15 eggs at 43. Just right there, you should be celebrating a huge victory and blessing. And how many PRPs? In the PRP world, this is just your own healing proteins. So there is a gradual improvement of whatever area you're trying to treat, and then it kind of plateaus at 3-4 weeks. It is accumulative. So I wouldn't, I usually will say, let's try 3, but I have a patient that I've been using PRP for hair loss. I mean, she had severe, like severe hair loss. Almost her head looked almost like chemotherapy type of hair loss. And she's on her 9th cycle, and now she can wear her hair down. So each patient is different. Okay. Can I opt out of getting hysteroscopy since I had 5 children because my tubes are tied? You can opt out. Now, even though you've had 5 kids, your body will change, and it is to your advantage that we do the workup. You don't know how many times I've had patients that want to cut corners and just to go back and finish the stuff that they did not do. So you don't need a hysteroscopy, but at least you should do a saline ultrasound to make sure that the cavity's okay, make sure that we're not dealing with sick tubes. I see that a lot with women that have had tubal ligations, and we end up having to take out the tubes because the remaining tube is accumulating gunk and inflammatory fluid. All right. Well, thank you so much for all your questions. I know I kind of skipped a few. It's just that they're coming in very quickly. I'll try to answer 2 more of these. All right, mini IVF. What is it about mini IVF? Anybody can do mini IVF. I think that's where IVF is going anyway. High doses are, more is not always better. Mini IVF works really well on women with high ovarian reserve and low ovarian reserve. It's a matter of getting less eggs that are a little bit better in quality. So, I'm definitely putting protocols with a lot less medication this day, and I've seen great results. Paratubal cyst does not need to be removed. It's really kind of, it doesn't have any effect on the uterus whatsoever. It's just a little bubble hanging from one of your tubes. It doesn't do anything to the tube, the ovary, or the uterus. All right, so like I was saying, you're always welcome to reach out to me. Again, I'm Dr. Verdiales. You can always send me a message through Messenger. If it's something that I can answer right there and then, I will answer you within 24 hours. If it's something that is a lot more complex, then I will make sure that somebody calls you and gets you on the schedule so we can discuss your case at more detail. So always lots of love from Georgia. May you all be blessed. Keep your head high and try to walk this path in love, because what is a child but the physical representation of love? And I know it's really hard, but I see it over and over again. It's when you have that moment of surrendering and peace and just letting go that the magic happens. And I want the magic to happen to all of you. So be all blessed and have a great next week, Thanksgiving. Bye-bye.